So before I talk about what's beyond basic, which is a relative terminology, so I would like to mention about the current guidelines, as the guidelines keep changing. Sorry.
So majority of the centers in India, to my understanding, follow ISUOG guidelines. Thank you. Which is a European guidelines, where the basic echocardiography is expected to complete a 4-chamber view. In addition to situs, 4-chamber view, both the outflows, 3-vessel view and 3-vessel trachea view, or the arches view. And everything else is sort of considered optional or advanced as per your wish or the requirement. But if you go to the American Heart Association and AIUM, slide is not moving, sorry. Okay, so that mentions a fetal echocardiography assessment like your postnatal echo. See as much as you can see, starting from situs, the complete segmental assessment, like how you do all the segments and look at everything which is seeable, including cardiac biometry, which is measurement of cardiac structures, Dopplers of outflows and veins, including pulmonary vein Doppler, and color flow of all the structures which you show in the 2D imaging. So you should know that there is, especially the trainees should be aware that there is a difference in between guidelines of their expectations. So I would say what is meant by beyond basics, in my viewpoint, is definitely it's a relative term. So whatever is optional or mentioned as advanced in the guidelines which you follow, or it's beyond whatever you're doing by your policy or by your center's policy. Or it may be what more can be seen in fetal echo as your expertise in technology advances. So what I'm talking as beyond basics is likely to be basic for few of you here who are already doing advanced, or maybe in between moderate one for who started doing fetal echo, or it may be too much for somebody who hasn't started fetal echo. So it's a very relative terminology. So that gives me a challenge on what to talk and what not to. But I'll try to include things which I see not being done so much in majority of the centers by my personal observation. So I'll start with the anatomy. So the bicable view, which is done as part of basic fetal echo, the long axis of the fetus, looking at the SVC and IVC and the RA, similar to your subcostal view. But I would like to mention that when you do this view, pay attention, go back to your situs view and make sure you're documenting the IVC there also. It's like a double documentation to say that IVC is right and anterior and it's connecting to the RA and it is normal, because isolated interrupted IVCs we do see in the situs ambiguous or some sort of heterotaxis where everything else can be normal. And also it's a good practice. AHA recommends putting color, but not ISUOG. So you can apply color and see the IVC and descending aorta in the opposite direction, flowing in the opposite direction. And one clue I would say to not to mistake a large hepatic vein from IVC. You see the direction of IVC flow. It flows from the spine towards RA, which is anterior. It flows posterior to anterior, and that's and it has an angle of around 25 to 30 degrees with the descending aorta when both of them meet the spine. So that's one clue. And the other structure which you don't get to see in all the fetuses is coronary sinus, because it's a much smaller structure and in the fetus. But like how you do in postnatal echoes, when you do a posterior sweep, that is where coronary sinus lies in the left AV groove posteriorly. So if you get lucky with good penetration, you may be able to see that in a normal fetus, so that you know when it's dilated, you know what you're looking at. So, and all of us know that gets referred as partial AVSD in a lot of cases because of the position. So moving on to the other vein, which is not routinely imaged, is the brachiocephalic vein. This has gained some importance in recent times, because you do get referral from obstetric scans saying there is an abnormal vessel flowing in the near the outflow. or abnormal flow, and what is the abnormality. So that is the indication for referral. So we know that people are looking at the fetal heart in more detail. So for example, look at this video. This was a late gestation fetus referred saying that there is an abnormal flow, abnormal vessel near the arches. So this is a bigger fetus, and you don't get this perfect apical views, sort of a lateral view where you can see both the arches meeting. The blue flows, both the arches meeting, ductal arch and aortic arch, and you see this red flow coming in between, just running horizontal. So that was a structure which had raised a suspicion of some abnormality. That is why this fetus was referred. For that, you should know how a brachiocephalic vein or innominate vein would look in a fetal echo. So we all know that that's a cranial most structure and anterior structure, anterior venous structure, and it should flow from left to right because it is going to join the SVC. So as you go from the three vessel trachea view, go to the cranial most section, you will see this structure running linear and anterior. And if you fill color, once you know the left and right of the fetus, it will flow from left to right. So if you can see that, it has two purposes. It can serve you two purposes. One is to know how the normal innominate vein looks, because we know when the abnormality happens, like in a TAPVC or in the left SVC, you can use it for your diagnosis. And sorry about the okay. So that's a sweep. I love sweeps, quick sweeps which are lasting for less than a second or a second, which can give you a lot of information. So this is a quick sweep from situs, apical four chamber to the arches, and the last structure you see, last in the sense is a cranial sweep. So the cranial most structure you see in 2D is the brachiocephalic vein, which is running horizontal. Okay, and the same thing is what I've shown. And this is the one with the late gestation, which is normal brachiocephalic vein, which we reported normal, so not to worry. And this is a case of TAPVC, where if you can appreciate that tiny dot is the vertical vein. And so you want to know what type it is and where it is going. You can change from the transverse section to a parasagittal or a sagittal section, and you trace it all the way up. So this is the head of the fetus. That's a tiny vertical vein. So that's the head. So you can see the red flow, cranial most structure, red flow where the vertical vein joins. So especially all these would help you to counsel appropriately and plan postnatal management appropriately. Moving on to the flap of foramen ovale, again has gained importance in recent years because two cases where HLHS, if there is a continuation of pregnancy, and TGAs, the foramen ovale is being looked at in later gestation, or you may have this isolated restriction of foramen ovale without any cardiac abnormality, which can present in late trimester with the right heart failure. So the same bicable view, you can tilt the probe a little bit, make it as a parasagittal view, and look for the flap. So you have to identify the left atrium, otherwise you'll mistake gestation flap, gestation valve for foramen ovale flap. And you look at the flap, and if you can get a lateral or near lateral view like this, and you should know where the left and right of the fetus is. So this is a left atrium. You see the flap should be on the left side because the flow is right to left. So in fetal life, the flap should always be on the left side. And this is the foramen ovale flow, which is flowing. It should be wide open flap valve in the LA, and the direction of flow should be right to left without a dot of aliasing. So that will help you to say that, because this is one of the three obligatory shunts, survival shunts. It should flow well, okay, as long as the baby is inside. So finishing the systemic veins with the ductus venosus, which most of the fetal echocardiographers must be doing, but I do see there's a lot of hesitation from the pediatric cardiology side to take a Doppler of ductus venosus, but it's not a big challenging job. It can be challenging if the mother keeps breathing very fast or if the baby is very mobile. But the clue is you trace it all the way from the umbilical cord and look for this hue. There will be a hue, which is an aliasing, because there is a change in the caliber. Whenever there's a change in caliber, there will be some aliasing. So that spot of aliasing is the location for ductus venosus. So you can take it in the long axis view, or you can take it in your situs view, upper abdominal view, situs view. Again, you look at the C curve of the portal vein, middle of the C curve, you'll have this hue, and immediately catch it before the fetus moves. And you should get a nice Doppler, which will mimic a pulmonary venous Doppler. Okay. The pattern will be very much like a pulmonary venous Doppler, and ductus venosus is a conduit. So there should be flow throughout the cardiac cycle, not touching the baseline without reversing. So make it a point. It's part of the basic echocardiography, but make it a point you learn to do it. And moving on to the pulmonary veins, all of you must be looking at least 2 pulmonary veins in 4-chamber view because they stare at you. If you get a good apical 4-chamber view in basal or apical, so you see 2. So 1 from each lung. These 2 veins are inferior pulmonary veins from each lung. So you're ruling out TAPs. Okay, but things get difficult when you don't have a good 2D image, especially with current generation of mothers coming with higher BMIs. So penetration is very poor. So you may see it in 2D and you may think it's LA, but it may be pulmonary venous confluence. So then color helps. So make it sure that it's also part of AHA and other guidelines to put up color in pulmonary vein to make sure you see the pulmonary vein draining into LA, because pickup of prenatal TAPVC can be as low as 10%. But if you get lucky and if you get a position like this and good machine, good views, you may be able to see 4 veins like this beautifully. You get a little lateral view of the turn the mother, get a lateral view, and you can see all 4 pulmonary veins. But one mistake or not reliable thing which I observed during my position is when we went back on those missed TAPVC images, quite a few we have shown an image like this on the top, thinking that the flow was into LA when the flow was actually into the confluence. So what I practice and what I teach and promote is just concentrate on 1 pulmonary vein, go to your apical 4-chamber view, put color, come down or at PRF, and pull the pulmonary vein all the way into the ventricle. I call it my pull-through technique. So you have 1 vein demonstrating going all the way, so you're ruling out TAPVC. We are not worried about TAPVC in fetal life, but for scimitar with the hypoplastic lung, there anyway the lung will give you the clue. Okay, that's something which I found helping, and there was no miss of TAPVC after we introduced this technique. And one more thing, not without color, is make it a practice to look at the retro-LA space, which will be widened in every type of TAPVC, intracardiac, supracardiac. Look at the retro-LA space here and look at the retro-LA space, because the LA is not anchored to the lung when there is the pulmonary venous. Okay, so that's a big clue, very big clue for TAPVC. Okay, that's with the veins. I don't know, we can see the veins probably in coming years. And moving on to the arteries, we are looking at the major outflows already in the basic views, and subclavian artery has gained a lot of importance because of isolated right subclavian arteries and its so-called chromosomal associations and stuff. But from the practical point of view, from cardiac defects side also, it's good to know the origin and the cause, especially when you have abnormal arches like right arch and left arch, whether you're looking towards a vascular ring. So it's good to counsel the family. So remember the anatomy very clearly. So this is the left arch with normal branching. So the dotted line is the trachea, and the last vessel is the left subclavian artery, which is posterior to the trachea. The right subclavian artery is anterior to the trachea. So you should remember that when you image, because fetal echo is all in transverse section when it comes to branches. So you have to think like a radiologist who's doing CT scan. So this is spine, this is the arches view. And so this is left and that's right. So the red dot on the right side is the brachiocephalic artery. It divides into 2. I'm not showing the carotid here, but there is a vessel going towards the shoulder. That is the right subclavian artery. This rounded thing is the trachea. So you have to identify trachea. Trachea has a black lumen and a white cartilage. Okay. And as the gestation improves, it gives you a better picture. But in 3-vessel trachea view, it's called trachea view because you have to identify trachea in fetal life. So that's the apical sweep. You go to the cranial sweep and you lower your color PRF, and the subclavian artery will stare at you if you have the fetus in the optimal position. Little oblique lateral view, not the straight apical 4-chamber view. So I'll run that again. So from 4-chamber, cranial sweep, apply color, know your left and right. So you label your left and right of the fetus and identify the trachea. So that's the trachea. This is right side. And there's a vessel going in front of the trachea to the right, and the vessel going posterior to the trachea to the left. So that's a left aortic arch with normal subclavian arteries. Okay. So if you follow that rule, then more often, unless in a very difficult position, you will be able to identify. And you have to be very careful when you counsel isolated ulcer, which is not that worrisome, but a lot of people get worried. So this is something for the trainees I would suggest is, as I said, I like sweeps, 2D sweeps, just quick sweep from without rotating the probe, quick sweep from apical to cranial. Same sweep, you apply color, reduce your scale, and do a quick sweep. This is like really few seconds. And as you can see, from pulmonary vein to right subclavian and brachiocephalic in one sweep. You can store it and look at it million times for you to, if you want to look at it and understand the structures. Okay. So when we are starting, so this is not the pulmonary vein, this is the pulmonary arteries. This is flowing towards and away. This is the branch pulmonary arteries. Apical four-chamber V, very low PRF. Then I have the arches, ductal arch and aortic arch. You see this not able to slow the speed. You see this tiny red flowing there, running posterior to anterior, draining into the SPC. That's the azygos vein. Some fetuses with everything normal can have a prominent azygos, so not to be worried. And then last comes, so that red running horizontal and cranial is a brachiocephalic. You have a nice thymus in the front, which is an additional info. And last, you get the subclavians. Okay, this is a very useful sweep. You get a lot of information just by lowering your PRF. Okay, so talking about the thymus, whenever you have an outflow lesions, especially tetralogy of fallow, so you can visualize thymus and report, at least report you can see it or not see it, even if you don't want to quantify, because quantification can have its fallacies or doubts. So again, a cranial sweep from four-chamber, then thymus will come straight under the sternum, as you know, in front of the outflows, and it will look like liver. Okay, it looks like fetal liver. It will have a slightly different echogenicity compared to the lung, but you can see it. So whenever you can see the thymus, say that, yes, I can see the thymus. There are two ways of quantifying. One is in the right subclavian view, if you can lower your PRF and get the internal mammaries, that's called the thymus box. In between the two mammaries, the thymus should occupy that space. Or you can measure the ratio of anteroposterior thoracic ratio and the stern thymus ratio, which should be approximately 40% plus. Those are what the other studies have shown, but I generally practice, if I see a nice thymus, I say thymus, because in definite hypoplasia, you don't see anything under the sternum, which has been proven postnatally. Okay. And so anatomy, 3D, it's very beautiful, but practically I use 3D, 4D stick for teaching because it gives you a real pathological information to the students. And it gives you an additional information, but it's not for basic diagnosis. It's not for basic diagnosis, but it can give you beautiful pictures of understanding the valves, especially prenatally. Like if you want to give maximum information to the surgical unit, you can give additional. This is the first one is the unbalanced AVST. This one is hypoplastic RV with the RV coronary fistula. You can see this tiny coronary fistula, so you can prognosticate. And this is some borrowed images where you can get venous and arch structures very beautifully done. It's a walk thing, so you can do just one apical stream and whole evening you can look at it and wow, how the creation is. That sort of a thing, but not for primary diagnosis. Fetal echo always humbles you because the creation is so wonderful. Moving on to cardiac biometry, measurement of structures is become part of basic in AHA, but all of you as pediatric cardiologists are like very familiar with measuring structures. So one thing I want you to be careful. Is be aware of the ratio. As the fetus grows, the ratio will change. The right heart becomes more dominant towards end of gestation. And then especially the one thing which remains constant is the ductal arch transverse arch ratio, because you're comparing two structures, as long as your aortic ductal arch is normal, which helps you to predict or anticipate caudation. And there are so many Z-scores available, so many nomograms. Whenever you're doing a serial assessment, please follow the same nomogram or same Z-score. Between two, like between Lee's and Schneider's, you'll see a big difference, plus 2.5 and plus 1.6. So you have to be very careful when you apply them and tell the people that, okay, this is very low. So, I always use ratios and z-scores. I look at the right-left ratio and z-score. So moving on to, I'm not going to talk about much about rhythm, function, and Doppler because I have speakers following this talking about it. Just related to the technique. In the technique of rhythm, remember the clue is catch the A wave. So you have to demonstrate the A wave by pulse Doppler. By Dopplering, your sample volume should Doppler the adjacent artery and vein, wherever the artery and vein are. Whichever artery and vein you get, Doppler and demonstrate the P wave in QRS or the A wave. That is a major. Then you're done with the rhythm. And inflow and outflow Doppler, same thing. Make use of valve clicks. So you place your sample volume closer to the valve tip, so you get the valve clicks. We are dealing with very tiny structures in the fetus, so we have to make it as reliable as possible whenever we image. And sorry, can I take? So that's a mode for rhythm and function. Again, four-chamber apical view. Go tangentially, diagonally opposite chambers, not LA and LV. Go LA and RV or RA and LV to get a atrial wall motion and ventricular wall motion, by which you define your P and QRS. There is one clue which I follow to get a P, because getting a P can be very difficult because it's a very tiny structure. I aim for the appendage. I put my cursor closer to the atrial appendage because appendage has muscles. So when it moves, your movement will be very obvious. So it makes life easy to identify the A wave in. So this is by applying near the appendage. So A wave looks prominent. Okay. 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 Fine. So I'll leave it to the other speakers about the function and advanced things. And just one last line before I finish. I think all of us have to be prepared to embrace artificial intelligence, as the coming years is going to be a big change in the field of imaging and medicine. And this is part of the project which I've been working with IIT Chennai. And there's a lot to come and a lot to evolve, which is going to make lives easier, especially in remote areas where there is no access to advanced technology. So I would say follow the fetus in every fetal echo, like an obstetric sonographer. Know the right and left, up and down very clearly. Follow the heart like a pediatric cardiologist in segmental way. See as much as you can see, and stay aware of the fetal dynamics, which keep changing as the fetus grows, and there's flaws related to it. Thank you so much.